For your return to sport testing with upper extremity injuries, are you looking at these 3 tests? Welcome everybody, Dr. Zach Baker, Chief Clinical Officer at Rehab to Perform, and just reflecting on another one of my Tuesday sessions. This time I was down at our Columbia location, and we have 2 PTs down there, Dr. Cal and Dr. Mason. And Dr. Mason and I were having a great conversation this morning on how do we really go about return to sport decision making with some of our upper extremity athletes when we don't have as many formalized clinical tests and different testing measures as we do in comparison to the lower body. And I think when we look at some of the return to sport metrics, a lot of the data, a lot of the formal evaluation measures that we have a larger number available for the lower extremity than what we do for our upper extremity. And we're oftentimes in a situation where we can't rely on the tests and the data as much as we can when we look at our lower extremity injuries in comparison to our upper. So what prompted this whole conversation was he has an individual who has shoulder instability. So they're having recurrent bouts of shoulder subluxation. So not having dislocations to the point where it's staying out for an extended period of time and needs to physically be relocated, but they are having, at this point, recurrent bouts of that subluxation where they're playing basketball and whatever other activities they're doing in addition to basketball, and they feel it go out, it goes back in. They have the period of discomfort, they have that little inflammatory phase that it goes through, and then the difficulty continuing to play at a high level and in a safe manner as well. So we were discussing what are some things that we go through when we're trying to figure out, is this athlete ready to play or not, assuming that it's already been discussed with the physician, the orthopedic, the other medical professionals that are playing a role in this, whether they're in the high school environment, collegiate, professional, or just your recreational adult or youth athlete. So making sure that we are having that interdisciplinary communication to make sure that we're all on the same page, that it is somebody that's a candidate for conservative management, or you've at least gone down the conversation of what would be indicators that surgery is now the best option and not just conservative management. So some things that we talked about were really just your basic stuff to get the ball rolling. So do we have full range of motion in isolated fashion, and then with some of our full range of motion through our functional and foundational movement patterns, reaching overhead, behind our back, reaching away from the body, different planes of motions, multiple joints involved, and is that any different than their ability just to demonstrate, isolated shoulder flexion or isolated abduction? What does it look like when you ask them to do combined abduction, horizontal abduction, and ER? Does that provoke something that maybe just one of those motions in and of itself didn't in isolation? What does their strength look like? Again, with traditional manual muscle testing, and then progressing maybe to either handheld dynamometry or isometric testing, or just tracking what they do through a strength training program. So when we start to look at their ability to do maybe body weight oriented tasks, push-ups, pull-ups, maybe something static in nature with a high plank or a traditional plank down on the elbows. What does that look like in a side plank standpoint? So we can get an isometric measure of muscle endurance and tolerance to a joint position that's elevated away from the body in a compressive nature as well. We can look at what they're doing in the weight room in comparison to their contralateral limb. So maybe we're doing dumbbell presses or dumbbell rows or overhead dumbbell or kettlebell presses. Can they exhibit the same amount of strength and movement quality on their injured arm as their uninjured arm? And then what does this look like compared to their pre-injury self as well? You can also look at those same strength room numbers and get an idea of what does the normative data for their age, gender, and sport look like. So do we have a 18-year-old offensive lineman, or do we have a 15-year-old female basketball player? It's great to see what their limb symmetry index looks like, injured limb versus uninjured limb, but how do they stack up against their peers as well to see if they're going to be able to withstand the demands of their sport when they go back out to the field or the court of play. We can look at different weight-bearing tests, such as the closed kinetic chain upper extremity stability test, where they're in a push-up position with the hands wide, and they are alternating, reaching hand to hand and getting as many repetitions in as they can in a given amount of time. We can also look at an upper extremity Y balance test, put them in a truly single limb support and have them reach out in 3 different directions to test that weight bearing tolerance and competence in some pretty exaggerated and vulnerable positions of the shoulder. Now, a lot of the tests that we just mentioned, especially the weight bearing ones, they all take place in more of a compressive or closed chain fashion. That's great if we're dealing with a fascia injury, but it doesn't take into account some of our open chain activities. So think about maybe a quarterback that has a shoulder dislocation because their arm gets hit when it's in this position. Think about a volleyball player who's maybe spiking or blocking and they're making contact with another person's hand or ball with the arm overhead. In this case, the individual was returning to basketball and they had a recurrent bout of instability when their opponent was trying to run by them and they brushed against their arm as the arm was going behind their body. So you also think about other moments, maybe they're a lacrosse player, they have to reach quickly for a ball, or they have to tolerate high velocity shooting and throwing where the arm's getting behind the body, hand away from the body, and then drastically following through with regards to the velocity of the motion and the total extent of motion that they're asked to do. So we had a good conversation of a lot of the time your return to sport testing looks like exercise that just mimics the demand of the sport. And you appreciate that you're never going to truly be able to mimic every single scenario and environment that they'll encounter, but you try to mimic the qualities that they're going to encounter. And then from there, it becomes just progressive return to practice and then eventually playing. One thing that we did talk about to supplement our compressive tests that we do are tests that are more distractive in nature. And this is really where the bulk of our conversation went to, trying to find ways to objectively quantify their tolerance and competence with long axis distraction of that shoulder. So we talked about 3 different hanging progressions that they can do. So utilizing either a fixed bar, like a barbell in a rack, or a TRX or gymnastic rings, having them invert themselves so they're parallel to the ground, holding themselves so shoulders are at 90 degrees. Can they do that for a period of 15, 30, 45, 60 seconds? And can they do that at varying widths or even in a single arm position? Then you can progress to going overhead. So can we hold from a pull-up bar? Palms out if we want a little bit more external rotation bias, palms in if we want a little bit more internal or maybe a neutral grip bias, depending on what the mechanism of injury is and what we're really trying to tease in or tease out with that. And then we got into a lateral hanging progression where we actually have them at a 45-degree angle with the TRX or the gymnastic rings out to the side, and they are leaning down towards the ground, shoulders at roughly 90 degrees of abduction, hand is positioned forward so the shoulder gets into external rotation, and we're putting them in that position that may be a little bit more vulnerable than just the 90 degrees of flexion or the overhead position. So with this upper extremity, you are going to have to take a little bit more of a holistic view at this. You may have to get creative with some of your testing procedures, but find things that you can quantify, find things that you can measure, make sure they're repeatable, and then the big thing, make sure that you can translate to your patient and within your documentation as how that's going to translate to their ability to tolerate their sport.